We all get stomach aches. Most of the time, they pass. But today, we are skipping the harmless cramps. I am going to give you an exact instruction manual for identifying a medical emergency that is ticking inside your abdomen. Appendicitis occurs when the opening of the appendix is physically blocked by unprocessed food or hardened matter. This traps bacteria inside, creating a pressurized, infected chamber that cannot drain. Your immediate dilemma is figuring out which reality you are living in, a bout of food poisoning that will be gone by tomorrow morning, or a blocked appendix that is actively swelling and requires a surgeon. When you aren't sure, the natural human instinct is to wait and see if the pain goes away. But with an inflamed appendix, time is your absolute worst enemy. This chart shows how your risk of severe complication multiplies over time. At first, the pressure is contained, but crossing the 24-hour mark, the tissue wall gives out. The risk line spikes straight up. The appendix tears open, spilling infectious waste into your abdomen. If you catch the inflammation early, you undergo a routine laparoscopic procedure and go home shortly after. If the appendix ruptures, you develop peritonitis. That requires open surgery, a heavy regimen of antibiotics, and a brutal, life-threatening recovery process that can take weeks. Deciding to lie on the couch and wait out severe abdominal pain is an active choice to multiply your risk of a fatal complication. You need to know exactly what to look for. The classic onset of appendicitis usually happens entirely unannounced, often waking people up in the middle of the night. And ironically, it almost never starts in the location you expect. Looking at this diagram, you see Kocher's symptom. The initial pain is vague and dull, registering centrally around the navel. Over the next few hours, inflammation spreads to the peritoneum. The pain physically drifts downward, packing tightly into the lower right quadrant. Because the pain is structural, movement aggravates it immediately. The cramps sharpen intensely if you walk, cough, laugh, or try to take a deep breath. This provides a clear contrast to food poisoning. If you eat bad food, your body wants to expel it, and vomiting typically provides temporary relief. With an inflamed appendix, vomiting does absolutely nothing to ease the sharp pain in your abdomen. You will likely lose your appetite entirely. Your body temperature may rise, but usually only to a low-grade fever around 37.8 degrees Celsius or 100 degrees Fahrenheit. Abdominal pain that physically migrates to the lower right side is the primary signal that the appendix has become a surgical priority. There is a dangerous myth that appendicitis always hurts perfectly in the lower right side. This comparison matrix shows how the appendix can physically sit in varying anatomical positions, completely altering where the pain strikes and causing the disease to masquerade as something else. If the appendix dips into the pelvis, the inflammation can rest directly against the bladder. This irritation mimics a urinary infection, leading to painful urination and a persistent urge to go. Because of this location, women frequently mistake the pain for gynecological inflammation, and men write it off as a simple urinary tract infection. Both assumptions lead to critical delays in seeking surgical care. Alternatively, you might have a retrocecal appendix. This means the pouch hides entirely behind the large colon.
When it swells, it presses backward, radiating pain into the lower back or down the right leg, closely mimicking a kidney stone. Relying strictly on the lower right side rule can cause you to dismiss a rupturing appendix as a bad back or a UTI. For children, the timeline is highly compressed. Their biological reactivity is much higher, meaning the inflammation progresses from a mild ache to a severe threat much faster than in adults. A distressed child may not articulate where it hurts. Instead, observe their body language. They lie rigidly in the fetal position, protecting their abdomen. Complicating matters, children with appendicitis frequently experience diarrhea. This makes it incredibly easy for parents to misdiagnose a surgical emergency as a routine stomach bug. Pregnant women face a mechanical complication. As the fetus grows, it physically pushes the internal organs upward. The appendix shifts higher, meaning the pain will register significantly further up the abdomen than the standard right quadrant. For these vulnerable groups, standard diagnostic rules fail. Any continuous, acute stomach pain requires professional imaging. There is zero room for guesswork. When severe cramps hit, your immediate human instinct is to reach for painkillers. Doing this is disastrous. Painkillers smear the clinical picture.
They numb your nerve responses, making it impossible for the Schettkin-Blumberg sign, where releasing pressure causes a spike in pain. You are blinding the doctor. You must also strictly avoid applying a heating pad. Heat acts as an incubator. It increases blood flow and rapidly accelerates the inflammation, pushing the appendix closer to the point of rupture. But the most dangerous illusion of all is when severe, localized pain suddenly completely disappears without any medical treatment. This sudden silence often signals the onset of gangrene. The internal pressure has choked off the blood supply so completely that the nerve endings in the appendix have died. You aren't healing. The tissue is losing the ability to transmit pain. Medicating the pain or ignoring its sudden absence allows the inflammation to advance toward a rupture without any further warning from your body. Appendicitis is a mechanical breakdown. It cannot be cured with pills, rest, or hoping it resolves on its own. This clinical scorecard lists the exact red flags to watch for: migrating pain, pain that sharpens upon movement, unrelieved vomiting, low-grade fever, and an abnormally tense abdomen. If you check even 2 of these boxes, you've crossed the threshold. You require immediate medical intervention. The wait and observe strategy is a real medical protocol, strictly reserved for patients already lying in a hospital bed under a surgeon's continuous observation. It is not for your living room. If you suspect appendicitis, follow a strict pre-hospital protocol. Eat nothing, drink no water, take 0 painkillers, and apply 0 heat. Call for help. Modern diagnostics have removed the guesswork. An ultrasound or a CT scan can look inside your abdomen and confirm an inflamed appendix in mere minutes. A false alarm might cost you an annoying evening sitting in the emergency room. Ignoring the warning signs of a rupturing appendix will cost you your life. Step away from self-diagnosis and let the ultrasound do the talking.